Good morning. The staff and faculty at the ECHO Institute and the University of New Mexico welcome you to the very first convening of the global ECHO community. We are honored and profoundly happy to be with you today. In fact, we are overjoyed to see you all here, live and in person, our partners from all over the United States and from around the world. It is wonderful to be with you. Before I continue, I have many people to thank, people who played a part in bringing us all together today. First of all, thank you, all of you, for being here. Without you, there is no ECHO community. Whether you came from near or far, you took time out of your lives to join us in celebrating and participating in this community. I also want to thank our entire faculty and ECHO staff who have worked so hard over the years to make our vision of a global community real. And thanks to the University of New Mexico Health Science Center and to Chancellor Paul Roth for providing a home for ECHO, and to Dr. Pope Mosley and Internal Medicine for their support. We have received so much support over the years from so many people and so many organizations. Our funders, beginning with the Robert Wood Johnson Foundation for their longtime support and for making this conference possible, the Agency for Healthcare Research and Quality, the Centers for Medicare and Medicaid Services, the GE Foundation, the Helmsley Trust, and very importantly, the state of New Mexico itself, our state legislature, our Department of Health, our state Medicaid department. Our partners in New Mexico, across the country and around the world, make this effort real every day. Thank you. Thanks as well to the Departments of Veteran Affairs, the Department of Defense, the Center of Disease Control and Prevention, the Association of American Medical Colleges, the Center for Healthcare Strategies, and to all the other government agencies and organizations that have joined up with us. And a very special thank you to our governor, Susana Martinez, not only for her support of Project ECHO, but for being here with us this morning. It is both an honor and a pleasure to have you here. We are all here as part of a strong and dedicated and vibrant community, a community that has important work to do together. We have a goal, and that goal is to touch the lives of 1 billion people by 2025. I'll say that again, 1 billion. That's a lot of people. To achieve that goal, we need you, each and every one of you. Together, we must make our ECHO community stronger, larger, and more connected. Project ECHO must become the norm for healthcare. It's the only way we touch 1 billion lives. For many years, our healthcare system has been locked in this paradigm that says that when you're sick, you go to your primary care clinician. But if you have a complex condition, your primary care physician will most likely refer you to a specialist who has the knowledge necessary to treat your condition. In this paradigm, specialized medical knowledge does not flow freely. Instead, it's often locked up inside teaching hospitals and major medical centers in big cities and has been disconnected from primary care clinicians on the front lines. So to access this knowledge and get the treatment you need, you have to go to a specialist. But what if that specialist has a long wait list, as many specialists in many disease areas do? And what if that specialist is located very far from where you live, which if you live in a rural area is not uncommon? For you to get the treatment you need, you either have to wait a long time or travel very far, or both. Maybe you wind up not getting the care you need at all. This is an inefficient paradigm, and it produces a great deal of unnecessary suffering and many preventable deaths from all over the world. And it is upsetting not only to patients, but also to clinicians who want to do the very best they can for their patients, whether they are specialists or primary care providers. I've been there. Project ECHO was born out of my deep concern of being unable to help the thousands of people in New Mexico suffering from hepatitis C who couldn't get treatment. Here in Albuquerque, we had a waiting list of 8 months for patients to get treatment for hepatitis C. And while they waited, they got sicker. This was unacceptable. Hepatitis C is a treatable disease and curable. The knowledge needed to improve and save these lives existed. But it didn't exist where it was needed most, in the communities where these patients lived. It was painful to see patients die of liver cancer and liver failure when their deaths could have been prevented by timely treatment. Oftentimes, the medicines to treat them were available, but the expertise was not. Because of the knowledge monopoly on this expertise, patients could not get the treatment they needed. I was perplexed by how to solve this problem, and then a solution emerged. We could connect our treatment team at UNM with community clinicians willing to engage with us over time to learn how to treat hepatitis C and provide the same quality of care that we provided at UNM. In this way, we would create a community of learners actively engaged in guided practice. In time, they themselves would become experts at managing a complex common disease that previously had been outside their scope of competency, and our shortage of expertise would be solved. And so this idea of ECHO and force multiplication was born. Today, the knowledge to treat hepatitis C exists in all communities all over New Mexico, and patients are getting not just care, but excellent best practice care from providers they know right where they live when they need it. We could get the right care to patients at the right place at the right time. This is what happens when we demonopolize medical knowledge, when we create a system that moves knowledge instead of moving patients. In this day and age, with the relatively inexpensive communications technologies that are available, it is far easier and far more efficient to move knowledge than it is to move people. When the knowledge to treat complex conditions resides in local communities where patients live, patients don't have to drive hundreds of miles in order to get care, nor do they have to wait months to see a specialist, when they can go to a community provider and get excellent treatment for their health problems. Our team was happy, very happy, with the progress we were making with hepatitis C through Project ECHO. Soon, other specialists at UNM approached me because they too saw a need for expanded treatment capacity in their disease areas. And they too wanted to share their knowledge as a way to improve access to care. Many of these specialists had huge waiting lists. For example, Dr. Joanna Katzman at the UNM Pain and Headache Clinic had a 12-month waiting list. Other patients had to wait long times to see a rheumatologist or an endocrinologist, and in rural New Mexico, it was very difficult for people to get treatment for substance use disorders. We realized that we could apply ECHO not just to hepatitis C, but to complex chronic conditions, including chronic pain and headache, complex diabetes, and rheumatologic conditions, addiction, and mental health disorders. Soon, we had a whole series of tele-ECHO clinics for healthcare providers across New Mexico. To date, 4,900 healthcare professionals in New Mexico have interacted with ECHO. These include physicians, nurse practitioners, physician assistants, and nurses. We have provided 63,000 hours of continuing medical education, and we have trained more than 500 community health workers in communities and in the prison system to help patients with diabetes, with addictions, and with hepatitis C. So that's where we were. That was all very good. It was wonderful. Project ECHO was really making a difference in people's lives, but only in New Mexico. And of course, the need for complex care isn't confined to New Mexico. It exists everywhere. In 2011, our team published a very important evaluation of Project ECHO in the New England Journal of Medicine. This evaluation, which was funded by the Agency for Healthcare Research and Quality, showed that community providers trained by Project ECHO to treat patients with hepatitis C were getting outcomes equal to those of UNM liver specialists. This evaluation put us on the radar of a lot of people all over the world. We had already begun our first few replications in Washington State, in Illinois, and in Massachusetts, and were working with the VA to start their own ECHO program Soon we were receiving requests from other people around the country who wanted to replicate ECHO, including the Department of Defense. By virtue of its power and potential, the simple idea behind ECHO of expanding treatment capacity exponentially through knowledge sharing began to spread on its own. A movement had started. We are now actively working to facilitate and support scaling of the ECHO model. Just 2 years ago, we had a handful of replication partners. Today, we have 40 ECHO projects in the United States and around the world. Many more are in development. I think I'm going to take a 30-second break and allow Governor Susana Martinez to enter. Hi. Thank you. Governor, welcome to ECHO, and we are honored that you're here, and we want to thank you for all your support of our project. So I'm going to start here. Just 2 years ago, we had a handful of replication partners. Today, we have 40 ECHO projects in the United States and around the world. Many more are in development. Yet, if we are to improve 1 billion lives, we need many more ECHOs. The need is overwhelming. Here in the United States, 5 million people have mental health care needs that go unmet every year. We are working on a way to link primary care with mental health care so that more people can get their needs met. In Northern Ireland, there is only one pediatric endocrinologist to serve 1,100 people, 1,100 children who have juvenile diabetes. One doctor, 1,100 children. ECHO can be used to train community providers in Northern Ireland and connect them with endocrinologists in the Irish Republic so both nations can meet the needs of their children. In Rio Grande do Sul in Brazil, the waiting list to see an endocrinologist is 7 years. 7 years. ECHO can complement the state's existing telemedicine network to train community physicians in the treatment of complex diabetes and endocrine disorders. Of the 170 million hepatitis C patients in the world, fewer than 10 million have been treated. More than 20 million will die unless more patients get access to treatment. We can help solve so many problems. Just think of all the pain and suffering and unnecessary deaths that we can prevent by working together. The 800,000 children all over the world who die every year of diarrheal disease, a completely treatable disease. The 3.4 million people who die every year because of diabetes, a disease we know how to manage. Think, too, how we can correct healthcare inequalities. African American women have the highest death rates from breast cancer of all racial and ethnic groups. They are 40% more likely to die of breast cancer than white women, even though they are less likely to develop it. Lack of access to screening and early treatment is part of the problem. We can help reduce health disparities by improving access. With ECHO, we can spread best practices more swiftly and more broadly. And even better, we can improve upon them. True best practices require the input of the community to bring us in touch with patients' lives and the challenges they face that affect their health. Can they afford the medicines we prescribe? Do they have social support? How far from care do they live? And what are their cultural and social norms? All of these things are important impacts. All of these things have important impacts on health. It is at the intersection of community and expert knowledge that we truly get best practice. Another challenge that ECHO addresses has to do with provider isolation. In a highly connected world, it is still possible to feel incredibly isolated. Primary care can be a lonely business, especially in a state like New Mexico, where there are a lot of small towns and rural areas. Even in urban communities, it is difficult for primary care clinicians to stay on top of the latest medical research and best practices, especially for conditions that are not within their current expertise. We can offer primary care clinicians the opportunity for continual learning and collegiality, regardless of where they are. They gain access to new knowledge, new colleagues, new mentoring, and supportive relationships. Let me share the story of Leslie Hayes. She's a primary care physician in a small town in north-central New Mexico called Espanola, which has high rates of opioid addiction. and the highest rate of drug overdose deaths in the country. Dr. Hayes has been in Espanola for about 20 years now, but she might not have stayed. With support from Project ECHO, she's now an expert in treating both opioid addiction and hepatitis C, conditions that were rampant in her community, but that she really couldn't do very much about before. What's more, she's trained others at her clinic to help manage and treat these conditions. As a result, hundreds of people in Espanola have been treated for opioid addiction and hepatitis C, people who wouldn't have been able to get this treatment before. Dr. Hayes has also expanded her expertise to manage problems like high-risk pregnancy and chronic pain, and her professional satisfaction has increased. As Dr. Hayes puts it, when you're in medical school, you're doing all this learning, but you're not contributing to society. But when you're practicing, you contribute a lot, but you're not learning. Now she's doing both. As you can see, Dr. Hayes' impact in Espanola has played out in several ways. First, her new expertise has enabled her to provide treatment services that were previously not available to her patients. All her patients, not just the ones she presents in ECHO clinics, benefit from her increasing expertise. That's what we call the primary touch. The secondary touch comes into play when the word of her expertise spreads, and all of a sudden she's attracting referrals from her peers for new patients in need of her services. And then there's the tertiary touch. New treatment capacity in the community has created new demand for treatment, and Dr. Hayes develops a team, including her physician assistant and a community health worker, all of who participate in ECHO to help meet the demand for these services. She educates her peers on how to screen and diagnose these conditions. So now, these clinicians have expanded expertise as well. In fact, she creates an ecosystem around her to improve care in her community. Dr. Hayes' story is just one of thousands that illustrate the power of the ECHO model. That power comes from creating communities of practice. What does a community of practice look like? In a community of practice, there are no knowledge monopolies. Knowledge is shared freely, wherever it is needed to save and improve lives. In a community of practice, there is not only mentorship, but friendship. Members of communities support each other because they all have the same mission of helping patients. In a community of practice, not only is learning ongoing, it is multi-directional. Primary care clinicians learn from specialists, but they also learn from each other, and they learn by doing. And specialists also learn from their primary care colleagues as new insights and innovations develop when this knowledge is applied to diverse populations in diverse environments. In a community of practice, people are enriched. When you share $100 among 10 people, each person winds up with just $10. But when you share knowledge, the math works differently. Because knowledge sharing and its application in diverse settings creates new knowledge. Everyone is richer. In a community of practice, the whole truly is greater than the sum of its parts. The community of practice is the source of our power. And it is through this community of practice that we will reach our goal of improving 1 billion lives by 2025. We are already on our way. I've seen it many, many times. In Espanola, in Gallup, in Carlsbad, New Mexico, in Washington State, in Chicago, in Connecticut, in Canada, and in India. All our partners have exciting stories, stories of hope and progress and collaboration where people's lives are being transformed. You will hear some of these stories today and tomorrow during the ECHO talks. Each story has its place in making our vision of touching 1 billion lives come true. There are many parts of our vision. There's our plan for big data. As ECHO continues to spread and more medical centers and clinicians join our community, we'll be able to aggregate our treatment data in a new and very powerful way. We'll be able to use these data to do failure analysis, to see why some communities don't do well. We'll also be able to identify new best practices and share them and develop new protocols for individualized patient decision-making. We'll be talking more about the potential of big data on one of our panels this afternoon. There's also a vision for the expanded role of academic medical centers to teach and train clinicians continuously and make lifelong learning and force multiplication a fundamental part of their mission. We need to help all health professionals keep pace with the exponential growth in medical knowledge, and we want academic medical centers to lead the way. We'll be talking a lot about that tomorrow. We have challenges, to be sure. Sustainability is always near the top of our list. How do we integrate this effort into the healthcare system so that it is self-sustaining? I believe we are making progress on this front, and we'll be talking more about this challenge in the next couple of days as well. But we believe our greatest challenge is not about funding. It's about our thinking. Can we think differently, each and every one of us, about how we add value to the healthcare system? Can we change our thinking around medical knowledge, who should have it, and how it is shared? Are we willing to demonopolize our knowledge for public good? Can we imagine a truly global eco-community in which knowledge does not define the boundaries of care, but rather creates free pathways for all people everywhere to get excellent care where they need it? Our answer is yes, yes. Together we can. Together we can expand our global community to its full capacity. Together we can teach others to do as we do, to build successful and sustainable eco projects and share knowledge and resources. Together we can find new champions in new places and get them to join our movement and share their knowledge and expertise. Together we can bring thousands more primary care teams into our communities and train hundreds of thousands of frontline clinicians and workers. Together we can improve the lives of 1 billion people on this planet. That is why you have joined us. This is the need we all recognize, and this is the power of our collective effort. Remember when I said at the beginning of my remarks how overjoyed we were to see you all today? It is because seeing you, being with you, makes this global community even more real and more alive to us. Ours is a community of practice, yes, but even more fundamentally, it is a community of service. And it is in service to others that we truly find joy. The Nobel Prize-winning Indian poet Rabindranath Tagore said it this way: "I slept and dreamt that life was joy. I awoke and saw that life was service. I acted, and behold, service was joy." My friends, ours is a community of service and joy, and our convening this week is about strengthening this community and strengthening our service. And it is about making real our vision of improving 1 billion lives. And that is why we are overjoyed to be here with each and every one of you. Thank you.